Good morning. Thank you, Dr. Zendil, for your introduction. And first of all, I would like to thank Kandy Society of Medicine and also Sri Lanka College of Cardiology for giving me this opportunity. Uh, Straight away, I'll go to the topic. It's about ST elevation myocardial infarction. I will briefly cover the initial management of ST elevation MI and start with the brief history. Mr. G, 51 years old and previously healthy patient, presented with chest pain for 3 hours duration. And the ECG done on admission. This is a real ECG, so it's not as clear as textbook ECGs. What you see there, and you can find that the T waves are very tall T waves with chest pain. Actually, this is a hyperacute stage of anterior ST elevation MI. So this patient presented very early stage of MI and the ST is elevated. So how do you diagnose ST elevation myocardial infarction? The history is very important. Typical chest pain, usually they will have chest pain, left-sided chest pain. They cannot point out the chest pain. If they point out with the one finger, it's unlikely a ischemic or a myocardial infarction. Usually they will say diffuse chest pain. They will usually show with the hand of their hand. And also they can have autonomic symptoms like sweating, vomiting, nausea, etc. And this chest pain might radiate to jaw in addition to the central chest pain or maybe along the left arm. Then we have the ECG, cardiac biomarkers, 2D echocardiogram, and finally coronary angiogram to diagnose ST elevation MI. I will go through briefly one by one because you only need two components to confirm the diagnosis. So if the patient comes with a typical chest pain and ECG is diagnostic, and further diagnostic tests are not necessary. So if the patient comes with typical chest pain and ECG is conclusive, your diagnostics part is over. But there are instances where the patient comes with vague history, sweating, maybe a diabetic patient, no chest pain, some other symptoms, and you will find that ECG of acute MI. So you need some other model to confirm your diagnosis. So the other modalities are there. Now ECG. How do you diagnose acute ST elevation MI? So new onset ST elevation at the J point in two contagious leads, more than 1 millimeter in all leads. So even 1 millimeter is significant except the lead V2 and V3, where V2 and 3 it has to be more than 2 millimeters in males more than 40 years, 2.5 in males less than 40 years, and more than 1.5 millimeter in females. So ST elevation 1 millimeter is significant except V2 and V3. Then apart from the ST elevation, what other information you can gather from the ECG? Timing. So you know that apart from the ST elevation, you can say whether this is hyperacute, acute stage, or even chronic, or the late presentation of myocardial infarction. And also size of the myocardial infarction, whether it is confined to a small area, a large area, or the location. Location is very important, especially for those who are doing interventions, which we can assume which coronary artery is occluded. Now this is a rough assessment of the location. You can see lead 1, AVL, V5 and V6 are representing the lateral wall of the left ventricle, whereas 2, 3 and AVF inferior wall, and V2, V3, V4 anterior wall. Likewise, you can localize the the territory of myocardial infarction. That will give us some other information, whether this is a small MI, large MI, also for us which coronary artery we can assume before proceeding with further management. But ECG diagnosis is not always straightforward. Sometimes you will find this kind of ECG where there are no ST elevations as such. But if you look at this ECG closely, you will find that all R waves in V2, V3 and V4 with ST depressions. This is a ECG of acute posterior myocardial infarction. Although by definition there are no ST elevations, this is equal to ST elevation MI in posterior wall, because since in a normal 12 lead ECG we don't record the posterior wall of the heart, so it will only record the reciprocal changes of the posterior wall of the heart. So what you see is only the reciprocal changes of posterior wall representing the anterior leads. So this you can confirm by extending your ECG leads to V7, V8 and V9, the posterior wall of the chest, but there even a 0.5 millimeter ST elevation is considered significant, and usually this is due to circumflex artery or posterior descending artery occlusion. The management is same as ST elevation myocardial infarction. And the other problem is left bundle branch lock with myocardial infarction. So this interpretation is very difficult with left bundle branch block, and because already there are ST elevations, already there are some ST depressions. So the Barbosa criteria is defined to diagnose MI in left bundle branch block pattern or even pace rhythm. The patients with pacemakers, they have left bundle branch block pattern. So pace rhythm and left bundle LBB, you can use this Barbosa criteria. The first one is ST. First one is ST elevation in a positive complex. If any lead has positive complex despite the LBB, and if there's ST elevation, even 1 millimeter is considered significant. Whereas the other criteria is if there's a negative complex in a LBB, generally there's ST elevation, but if it is more than 5 millimeter, that is also considered as a significant. And with the negative complex, if there's ST depression more than 1 millimeter with positive T wave, again considered as a positive criteria to diagnose MI. So there are marking the point systems given 5, 3 and 2 based on the presence of these things. These are not very sensitive but specific. If they are there, it's very specific to diagnose myocardial infarction. So that will help to diagnose. This is a patient with pace rhythm. You can see pacemaker artifacts are there, and the myocardial infarction. See the lateral leads as ST elevation, positive complex with ST elevation. So this is a pace rhythm with MI. And this is a left bundle branch block. So there's no myocardial infarction, just a simple left bundle branch block. And echo. Is there a place for echo in diagnosing myocardial infarction? Yes, when the especially situations like left bundle branch block and patient comes with chest pain, and you can do the echo as a bedside test when the ECG is uncertain. And here we can detect the new onset regional wall motion abnormalities. It again high sensitive but not very specific to diagnose MI. And the cardiac, few words about cardiac biomarkers: troponin I, troponin T, and they are very sensitive. Nowadays we have high sensitive troponin, and troponin starts to rise blood level within 2 to 3 hours of myocardial infarction and peaks in about 48 to 72. So the peak level of troponin will be somewhere between day 2 and day 3, and thereafter it gradually declines like shown in this graph. So this the yellow line is the place where your test can detect the troponin. So if the patient comes with chest pain of 1 hour duration and doing troponin is not very helpful, but you can do your troponin will detect in your blood test generally after 2 to 3 hours, even the high sensitive ones, and after 2 or 3 days it will become maximum level, thereafter gradually declines, and it will there for another nearly about 14 days. So a patient discharged from ward after treating myocardial infarction and coming in day 10 perhaps, if you do the troponin it will be anyway positive, but make sure that whether this is a reinfarction or not is a bit difficult to interpret. In that instance, what you can do is you can repeat the troponin in a day or two. Yeah, it should be in a decline phase. If it is going up, that means the patient had another myocardial infarction. So that's a common scenario we encounter, because once we discharge patient with aspirin and all these things, because of the gastritis, stress, everything, they tend to come back with another chest pain. They are very anxious, and there are ECG changes, so ECG is not diagnostic, and if you do the troponin it will be positive, and you have to repeat the troponin in maybe 1 day time to find out whether it is in the decline phase or going up. And there are many causes. It's a busy slide, I don't want to go one by one. There are many causes other than MI, many cardiac causes where you get positive troponin. So that is again something that you have to remember, especially cardiomyopathies like hypertrophic cardiomyopathy will have ECG changes and troponin becomes positive. In that instance, you can again, what you have to do is you can have to repeat the troponin in few hours time to find out whether it's a static level or going up. And chronic renal failure is another instance. I don't want to go each and every instance. Finally, the coronary angiogram is another modality to diagnose. It's not only to treat the myocardial infarction, you can use this to diagnose the myocardial infarction. We have two modalities, invasive coronary angiogram and CT coronary angiogram is the newest one. Unfortunately, we don't have it in A&E situation, but CT coronary angiogram is a good method to rule out myocardial infarction. If your CT angiogram is normal, you can safely discharge. Uncertain patients, troponin not positive, but some suggestive chest pain, ECG vague, and in that instance, you can do a CT coronary angiogram. It's done in developed countries where the facility is available, and if it is if the CT is normal, you can discharge. So it's basically to rule out myocardial infarction, you can do CT coronary angiogram. So what should we do in the emergency department? Make the diagnosis within 10 minutes. So patient coming with chest pain, we should be able to make the diagnosis within 10 minutes by doing ECG, IV access, oxygen, I will discuss that. And usually patients complain is pain, so you have to do something. Always use intravenous route. Avoid intramuscular injections in myocardial infarction patients, because subsequently you might give anticoagulant, thrombolytics, etc., and patient might develop hematomas if you give intramuscular injections. And oxygen, now early days we used to give oxygen to everybody coming with chest pain, and now the practice is to give oxygen when the saturation is less than 90 or the PO2 less than 60% in blood gas analysis. So if the patient maintains saturation above 90% without oxygen, so when you don't have to give, because some trials have shown the hypoxia may be harmful to the patients. It might, the uncomplicated MI especially, may be due to free radical formation, might cause more damage. So this the same patient, while we have the ETU team is doing the IV access and things, somebody noticed this in the cardiac monitor. What is this? is actually ventricular fibrillation. So this can happen to anybody coming with very stable myocardial infarction, and any minute they might end up with ventricular fibrillation. So they need immediate non-synchronized DC cardioversion. Now it is very important to connect these patients coming with myocardial infarction to a cardiac monitor with defibrillator facility, or else at least the defibrillator should be ready on the bedside, because ventricular fibrillation is something that you need to treat promptly. If you don't, patient might go into hypoxia and you will have to ventilate and a lot of issues after that. And not only ventricular fibrillation, they might develop this rhythm, the ventricular tachycardia. Some of them are stable pulse, some of them are pulseless where the blood pressure is not recordable, or they might suddenly go into complete heart block, severe bradycardia, especially with inferior myocardial infarction. So cardiac monitoring is a must. And what are the pre-medications that is given in emergency department or ETU? So generally, patients with myocardial infarction, they will need antiplatelet drugs, and so now we are giving dual antiplatelets, aspirin plus another one, P2Y12 inhibitors. Clopidogrel is the one that everybody knows, but the prasugrel and ticagrelor are relatively newer to our country and again available. They are more potent. And statins, and I will briefly discuss about anticoagulant and GTN in acute myocardial infarction. Generally, we don't not give GTN. GTN is not very useful in ST elevation myocardial infarction because it's a total occlusion of artery. So by giving GTN, it will not relieve the pain. Sometimes it might drop the blood pressure. But in special instances, if you are suspecting coronary spasm, some patients will develop chest pain, ST elevation, and suddenly it will disappear. So in that kind of patients with the chest pain, you can give GTN to see whether this is coronary spasm. Other than that, there's no place of routine GTN. And aspirin is loading dose. Loading dose is 150 to 300 milligrams. And ideally, we should give non-coated formula, but it's not available. What we have is all the coated formulas, so you can crush them and give the patient. And other the loading dose of antiplatelets, clopidogrel, generally we give 300 for prior to thrombolysis, but planning for primary PCI, dose is 600, not 300. And the other two drugs, prasugrel and ticagrelor, are studied for primary PCI setting, not before thrombolysis, because these things are more potent and might cause more bleeding. So the loading dose of prasugrel is 60 mg, followed by 10 mg daily maintenance dose. Ticagrelor is 180 mg, maintenance dose is 90 BD. And other antiplatelets also available in worldwide, like Cangrelor, but we don't use that. It's an intravenous antiplatelet. And glycoprotein 2B 3A inhibitors direct, you can give intravenously. They are used especially reserved for cardiac interventions, not for thrombolysis. Abciximab, tirofiban, and MT5. And what is the next step? And that is the reperfusion. So STEMI is usually caused by total occlusion of a major coronary artery. So 1 hour after total occlusion, about 40% of the myocardium will die. So time is precious in this situation. Now this is a slide that I copied from ESC guideline, published 5 years back. So how do you decide whether PCI or thrombolysis? That's the time. Main determinant factor is time. If you can arrange PCI within 120 minutes from the time of admission, that you should go for a primary PCI strategy. So it may be available in the same hospital, it may be available in a nearby hospital. So if you can transfer and do the PCI within 2 hours, that's the form of treatment. If that is not possible, you should consider thrombolytic thrombolysis as an option to treat these patients. So if you are deciding thrombolysis, it should be given within 30 minutes from the admission. So diagnosis 10 minutes, and within next 20 minutes you should be able to give the thrombolysis without further delay, because as we know, time is very important. And primary PCI improves survival compared to thrombolysis and reduce the reinfarction and decrease major bleeding, not like thrombolytics where we have seen severe adverse effects during thrombolytic area. That major bleeding risk is very much less with primary PCI, and primary PCI compared to thrombolysis saves 53 extra lives per 1,000 patient treated. This statement I copied from about 10 years back, where the bare metal were used, and now the results must be even more than that. Nobody is doing research nowadays comparing primary PCI versus thrombolysis, because if primary PCI available, that's the option of treatment. Few words. Door to needle time is the time from admission to ETU to the starting of fibrinolysis, and door to balloon time or door to wire time, or the sometimes called door to device time, is the time from admission to ETU to the wire crossing of the occluded artery. And FMC is the first medical contact. These are some of the terms used in ST elevation myocardial infarctions. So this is our patient, Mr. G. Angiogram showed that the anterior descending artery is totally occluded from this point. So what did we do? We managed to cross the wire and a balloon and inflate the balloon across the occluded coronary artery. And finally, stent is placed across the occluded artery. So this is how the primary PCI is happening. Nowadays, radial access is the preferred mode of access, because they significantly reduce the bleeding, radial artery access compared to femoral artery access. And the stenting is not the option for all the time. Some of these patients, now this is a 28-year-old patient coming with inferior ST elevation MI. You can see there is filling defect in mid right coronary artery, plus there are filling defects involving the distal coronary artery as well. So this is a large thrombus, and instead of putting stents, he underwent intracoronary thrombolysis treatment. There are other options like thrombus aspiration. We did not have that at the moment, and that will establish the distal flow. Although you can see the thrombus in the middle of the artery, but since he was free of pain, we stopped at this point without putting a stent. We are going to check this patient's angiogram in few days time, so it may be open. And this is what we have done since 2018. This is a teamwork. A number of primary PCIs we have done. We started our 24/7 primary PCI program in 2018. There's a big team involved, and day night it happens. And we must also thank our ETU, because not like old days. Nowadays they are sending patients immediately, so we are managing to keep the 1 hour door to balloon time due to the efficient ETU team. And one interesting thing I found is that in 2020 the line is compared to the 2018, 19 and 20 is very high. So we are experiencing more myocardial infarction this year for some reason. I don't know. is actually when I gathered the information only I detected this. And a few words about thrombolysis. Streptokinesis is the one that we use for many years, nearly 2 decades, and it has to be given as a 1.5 over a 1 hour duration infusion, which is a cumbersome thing, and it was replaced later by tenecteplase. It is more thrombin specific and given based on the patient's weight. So 30 milligrams for those who are less than 60 versus increase based on the weight, and it is given as a single bolus. So it's very easy compared to streptokinase. And if you are sorry about that. If you are thrombolizing, these patients need enoxaparin also, followed by thrombolysis. They will need enoxaparin. That is generally the dose is 1 milligram per kilogram, but above 75 we tend to give 0.75, or if the patient is in renal failure where GFR is less than 30, then we have to give daily dose. And instead of enoxaparin we can use unfractionated heparin, but ideally it should be monitored. And fondaparinux again available sometimes back, nowadays we are not using. And what should you do following thrombolysis? If the patient undergoes thrombolysis, there are two options. One is rescue PCI and pharmacoinvasive. What is rescue PCI is done when the patient failed to achieve successful thrombolysis. So patient may be having ongoing chest pain. If you do the ECG 60 to 90 minutes, so 1 to 1.5 hours after the thrombolysis, it should be less, more than 50% of the STs should come down. So if you take the maximum ST elevation, any lead, that should come down by 50% in 1.5 hours time. If it has not happened, then there's a indication of failed thrombolysis, and the patient may be in cardiogenic shock, may be in pulmonary edema, or may be having resistant arrhythmia. Those are the signs of failed thrombolysis, and these patients need transfer to a facility where there's a PCI immediately. So pharmacoinvasive strategy is the other one where you decide that you cannot offer primary PCI within 2 hours, and you give the thrombolysis. Irrespective of the response, you transfer for PCI. That is pharmacoinvasive, and it's done in foreign countries. Unfortunately, we cannot accommodate all the MI patients in this region to do this. This has shown almost equal results compared to primary PCI alone. And following a myocardial infarction, hospital stay, we generally keep the patient in coronary care unit for the first 24 hours. Uncomplicated patient we mobilize after 24 hours. And hospital discharge, if you do achieve successful primary PCI uncomplicated myocardial infarction, 24 to 72 hours we can discharge. So that's another big advantage over thrombolysis, where you have to keep at least 5 days after thrombolysis. If we successfully do the primary PCI, we can discharge 24 to 72 hours. Since we do not calculate the hospital stay as a cost, we don't have idea about the advantage of doing primary PCI, but in foreign countries they will calculate the cost of hospital stay as well. So this will dramatically reduce the cost because of early discharge. Thank you.